Um, my talk is on TYK2, and I appreciate IPC inviting me to do this. And I'm a community dermatologist, a clinical dermatologist. I do research. I've done the pivotal clinical trials. I enjoy it. In my practice, I'm one of those dermatologists that only sees two things. I see skin cancer, of course we have to, and I see psoriatic disease. That's all I do in my practice. And so obviously I don't like itchy people, and I don't like people with no hair, and so forth. So I know there's things for that, but I have dermatologists that do it. Sorry, Richard. Yeah. So this talk will be sort of the way I think. And I find that, you know, when a lot, and oh, this is where I live. I live in Hamilton, which is in Canada, which is between Niagara Falls and Toronto. So for those of you who've never been there, it's pretty nice. It's sort of close to just about everything. And this is what it looks like from the top of the mountain. So I know people show this at the end. I figure I just get it over with at the beginning as well. And this is what it looks like now. So this is about 1 kilometer from where I live. There's a lot of waterfalls where we live. And so obviously with a lot of waterfalls, we have the big falls, the Niagara Falls. These is just little falls. And also our toilets flush very, very well because of that as well, as you could imagine. These are my disclosures. I guess I learned from somebody to say that my only conflict of interest are for companies that I don't work for. So otherwise, this is all good. So this talk is going to be sort of the way I think of things, and I think a lot of times that we have these intelligent speakers from before that assume that we understand everything that they're talking about, and even myself, I don't understand everything. But so I'm going to try and present this in a way that will help you understand. So basically, you've seen this slide before. Some people call it a cartoon, and actually you will see a cartoon later that I develop. So basically, if you look at this, this is basic, psoriasis is just caused by a bunch of olives and little pieces of cheese and so forth, and these squiggly things that we're all trying to figure out. There's just so much cytokines, and just as another speaker said, you know, maybe the fibroblasts have something to do with it. Basically, we are really not sure what is going on, right? And so we were put here on Earth to just try and figure things out. And the more we figure out, the more questions that we tend to have. And the new questions that we have is by looking at TYK2. So it's just another way. You know, we thought we had psoriasis, and we said, yep, it's T cells, and that's all it is, and just inhibit the T cells, and then inhibit TNF, and then inhibit IL-12, and then IL-23, and P40, and anti-IL-17, and then anti-IL-23, and then JAK inhibitors, and then we came out with like TYK2 inhibitors. It's like, oh, where did this come from? This is sort of where it came from. And the key thing is that it still works through IL-23. So you know we call IL-23 the master cytokine, and it still is. It's still what's causing a lot of the problems, and the mechanisms for blocking that all have to do with IL-23. So we know that IL-23 binds to the cytokines, and then it activates this JAK-STAT intracellular signaling pathway. Now, some people, you go right and you forget about this. You say that IL-23 stimulates a cell, creates a Th17 cell that makes IL-17. Sure, but how does it really do that? It does it through this JAK-STAT pathway, and it cross-phosphorylates, and then you have this cytokine binding, and then because the STAT gets phosphorylated, it leads to their activation, and that is sort of what makes the IL-17. So it's not just activating, it's coming through all these different mechanisms, and that, from some kind of genetic predisposition or whatever it is, that causes the plaques to become red, thick, and scaly. And that's what causes a lot of people to be miserable. And so we know that that is important, but interferon also seems to be important. And so this pathway is not only important for psoriasis, but other skin diseases like lupus, but other diseases like inflammatory bowel disease and psoriatic arthritis. Everything seems to be all together. And yeah, we work a lot with rheumatologists and we work a lot with gastroenterologists and immunologists as well. But I still think that there are really only two types of doctors in this world. There are dermatologists and those that wish they were dermatologists. I think that that's what it is, right? I mean, it's like, oh, just put hydrocortisone on it. Sure, that's all we need to do. So what is the difference between JAK and TYK? And I'm a little bit disappointed that TYK2 inhibitors are still grouped together with JAK inhibitors, because I really think that they're different, because JAK inhibitors still have these immune functions, and they still work very, very well, but they also have this non-immune homeostatic type of functions as well, which we don't see with TYK2 inhibitors. And that's why the TYK2 interests me, and I find that it's interesting because it only works on those immune functions through IL-12/23 and then through the interferon pathway. Okay, so that part's easy. So now if we just take that little TYK2, we take the TYK2 molecule and we look at it connected with JAK, we see that the regulatory domain is that TYK2. So what's the regulatory domain? It's different across the family members. That's why when you give a TYK2 inhibitor, it has to be a specific TYK2 inhibitor that works on that regulatory domain. So you'll see later that regulatory domain is sort of what controls everything. So it's sort of like my wife would be the regulatory domain, or maybe even, I would say, a compliance officer in a company, right? They're the regulatory domain. And then you have these other family members, these active domains. So that's me. I want to go golfing. My boys want to do something, and my wife is the regulator, and her answer for everything is anything cool that we want to do is two words: not necessary. So that's what she says. I say, let's take a helicopter and let's go, in the Grand Canyon. Not necessary. Let's bungee jump. Not necessary. And so she is the regulatory domain. And I told her this, and she agrees. And I agree, of course. I have to agree. So we have this active domain, and that is similar. So you can take any JAK inhibitor, and it competes for that JAK area, and the TYK has to be specific for that. So we have all these terms that are used, and I remember at the World Congress, I heard a lot of terms. Bruce Strober gave a great talk about this, and it was sort of like, what do you mean? Like, what is regulatory? And then we interchange terms like allosteric inhibition or regulatory inhibition. So the allosteric is the regulatory inhibition. If you block that, nothing can happen. Okay? But what is catalytic? Catalytic inhibition is like competitive inhibition, and that's traditional. We have, all of a sudden, we always have something that's traditional, right? Traditional systemics that we have. It's like, really? It's like, we have methotrexate, cyclosporin, acitretin in Germany, fumaric acid. Traditional. Only fumaric acid is traditional in Germany, right? Yeah, it's still trying to get out there, but it's not, so it's okay. And I think only German patients respond to fumaric acid anyway, so it's okay. So we have these interchangeable terms. So there's our compliance officer. That is the regulatory part. And then we have the business end, which is the rest of the company. So if the compliance officer says to the rest of the company, you can't do this, you can't go here, you can't do that, nobody does anything. Okay? You just can't do it, nothing happens, and so nothing gets activated. However, if you affect just the business end and the rest of the company and you don't have a compliance officer, you have all kinds of people doing things, and then sometimes you'll have a boss that'll say, no, I'm sorry, you can't do it, and so then you have that type of inhibition. And that's that competitive type of inhibition instead of the allosteric. I hope that makes sense, okay? So what exactly is that? So we have this mechanism of JAK inhibitors that work on that active domain, and you have this conformational change because you have difference in there, and that's by the phosphorylation, and then you have ATP that goes in there, and that's what causes the active state. So that is competitive inhibition for the ATP and the JAK inhibitors. It depends who gets in there first. So if the JAK inhibitor gets in there first, you're not getting this phosphorylation, and you're not getting the JAK signaling, and then you have this inhibition that is occurring. So you see that there's a competition because the circle fits into that square. And people next door agree, and they're clapping because of what I just said. Yeah, or they're happy that the last speaker is finished or something. I'm not sure. And then we have these TYK2 inhibitors that are active in allosteric inhibition. So you see the domain remains the same. If you have a conformational change and by phosphorylation, you can still have ATP going in, and that is active TYK2 inhibition signaling. But if you have that's allosteric and you affect that regulatory part, it locks that TYK2, that ATP can't even go in because you have that active domain that just won't work. Okay? So you have traditional, which is competitive, versus allosteric. There's your traditional on the left and your allosteric inhibition on the right. And if you think of it as circles and squares and that you can't do anything if you affect that allosteric inhibition, it makes sense. Okay? I haven't even got to the names of the drug yet. This is just so basic science, but I hope that that makes you understand. So what I did is I created something called a fiver. Do you know what a fiver is? F-I-V-R-R. So what it is, it's a website that'll do videos for you or cartoons. So this is a real cartoon. So what I had done is I had asked the main scientist from BMS that did Deucravacitinib, can you put it in a simple way that I understand what's going on? So this is how he explained it, and I decided to make a cartoon out of it. I hope that it works. It's short.
Let's explain the difference between catalytic and allosteric inhibition. I don't want my two sons driving my car. I give them my keys. They get in my car, start it, and as it's moving down the driveway, I jump in, push them away, and hold the steering wheel tighter than they can. This is catalytic JAK inhibition. With allosteric inhibition, I lock the car and don't give them the keys.
So that's a real cartoon, okay? Thanks. So now let's look at some of the drugs, okay? So we're going to do this sort of in order, and there's not a lot of data on this. So we have brepocitinib, and we have ropsacitinib. So what about brepocitinib? So this is a catalytic inhibitor. So remember, this is competing, and this is a Pfizer molecule, and it was done in phase 2A studies, and this is the explanations on the top. But basically, we're looking at a change of PASI score, and you can see, without going into details, that we are achieving this reduction in PASI scores. And because it's early phase, it's hard to say what is going on if it's 30 milligrams, and you can see the dosage is all over the place with induction. And then if you look at the same dose throughout, and then you can see here that you have that 30 milligram dose, and by week 4, you're still having a reduction of PASI score, and by week 12, you have a further reduction. So bottom line is that it works. What about trying it topically? Does that work? So the answer is, and if you look here, if the application is once daily or twice daily, the problem is it didn't show any statistically significant changes. So topically, it just didn't seem to work, but at least in the phase 2B. Now, what about ropsacitinib? So this is another type of Pfizer molecule, and this is a catalytic inhibition. And now we're looking at not only PASI 75, but PASI 90 inhibition. And we can see that at a dose of 40 milligrams once a day, we have approximately a 50% reduction in PASI 90 by week 16. So what I explain to the patient is that you have about a 50% chance of being clear or almost clear by week 16 with this catalytic inhibition, and of course a higher PASI 75 as well. But I use PASI 90 as clear or almost clear to explain to the patients. Now, Deucravacitinib, you know, not every country has it, and in Canada and United States, it's called TYK2, and that's a good thing. I don't like the so, because it's like, so, TYK2, you know? But it is, it's like, it should be like, wow, so TYK2, in a way. So we have an allosteric inhibition. And this is the blocking that regulatory part, and there's two different studies, Poetic 1 and Poetic 2. We're not going to go into details. And here we see, compared against the Premolast, we see a significant improvement. Now you may say, well, sure, Premolast doesn't really work that well. It works. I have a lot of patients on a Premolast, and it does work very, very well. And I always looking for something better, and here we can see that we have almost twice the amount of patients that will respond to a PASI 75 compared to a Premolast in Poetic 1, and almost 60% in Poetic 2 with a once daily dosing of 6 milligrams. And then if we're looking at patients that are clear or almost clear, we have about a 60% chance by 6 months, and Poetic 1 and Poetic 2 in NRI analysis, we have about a 50% chance of being clear or almost clear by using the SPGA. Okay, but we know we don't have psoriasis just for 16 weeks or for 6 months. We have psoriasis for longer term, and we have this maintenance of effect by maintaining PASI 75, PASI 90, and PASI 100 in Poetic 1, and clear or almost clear as well in Poetic 1. So we're seeing that half the patients can maintain their dosing. So it shows that a once-a-day pill, which a lot of patients prefer, and I don't believe it's because of needle phobia. I think that that's marketing, schmarketing. But I think that some patients just like to take a pill once a day. That's it. They're like, you know what? I'm going to forget to take a needle twice a month or once every few months. I like taking my pill once a day. And like Richard said, it's transportable, and patients do like it. But it's not always because of needle phobia. Now, does it work about 2 years? Yes, we have. If you take the patients that did do well and that had a PASI 75 response, it continues. And at this conference, you're going to see 3-year data as well, showing that you have extension of this effect of PASI 75. So you have 90% of patients that will maintain their PASI 75 response. I will say one thing about it in my clinical use. I have about 50 patients on TYK2 in my practice in Canada, and it works, but it's a bit slow. So I will say that, but that's okay as long as you explain to the patient. And here, clear or almost clear, maintaining that 60%. But what about the side effects that you can see with JAK inhibitors? It is what I would call boring. You're not seeing anything. And in Canada, we do not follow the FDA guidance and some other countries like Chile, that in terms of monitoring. We do not have to monitor in Canada. We do pre-blood work, just as we would for any biologic, but monitoring is not required because it's boring, it's flat. There's nothing that happens with the lymphocytes, with the neutrophils, the hemoglobin. But I know with FDA, you have to monitor CPK. I'm not sure why. It's pretty flat, and ALT, pretty flat type of lines, and even triglycerides as well. But that does need to be monitored in some countries, so just be aware of what your product monograph says. Now, what about ropsacitinib as a catalytic versus deucravacitinib as an allosteric inhibition? You can see some changes in hemoglobin, as I mentioned before. Because you have that little bit of JAK inhibition, you may have some changes in the hemoglobin. So what about another allosteric inhibition, the Takeda 279, which used to be a Nimbus molecule, which is now changed the name, Takeda. So maybe this will be called TACTIC2. I don't know. Maybe that's a good idea. Warren, what do you think? attack TYK2. That could be good. We'll see. So here we're looking at different types of dosing, a different type of, really a different type of molecule as well. And you can see that it has very, very high affinity for allosteric inhibition. And when looking at Takeda, the Takeda molecule versus the BMS molecule, both really are very potent for TYK2 inhibition, and you need very, very little drug for that TYK2 inhibition. For Takeda, you need a lot more than you do for Deucravacitinib, but that's still that 0.33 nano, that 0.33 for Deucravacitinib, it's not clinically significant. It's a number, it's depending on how the assay is done. But we don't see the JAK effects with either of these molecules. So does it work? Yes, it does work. So when looking at the proportion of patients with PASI 75, you have about 70% of the patients with a 15 milligram once a day dosing. However, when you're looking at PASI 100 to 30 milligrams seems to be better with about 32% of the patients that can achieve a PASI 100. So with an oral molecule, your patients can still be clear. And again, the hematological parameters in the CPK are boring and nice and flat and not any concern with liver function tests, renal function tests either at all, or any of the lipid parameters. And I agree, that is worth applause as well. I think we're going to hear this. We're going to hear this all week. So, in conclusion, TYK2 is a key mediator for inflammation, not only for psoriasis, but for other immune-mediated diseases. It works through the anti-IL-23, the master cytokine, which works through IL-23, IL-17 axis as well. And then we know that the cytokines can play major roles, such as TYK2-mediated cytokines in other diseases like inflammatory bowel disease, psoriatic arthritis, and with lupus. And with that, I want to thank you very much. That's the end of my TikTok.
Thank you very much, Ron.